and I'm going to introduce you. So good morning, everybody, and welcome to our New Brunswick Heart Center academic rounds. And this morning, it's my pleasure to have Dr. Aimee Noel, our heart failure specialist, talk to us today on tips and tricks for the treatment of the long lost ventricle. You might guess what that is. Anyways, Aimee, with that, I'll let you start.
Awesome. Thanks, everyone. Thanks for the great turnout. I hope I don't disappoint. If you guys want to ask questions along the way, please just interrupt and we can kind of talk around this. But treating the long lost ventricle is essentially the RV, and it's something that I find very interesting and definitely challenging. So we'll just go right into it here. And my hopes here were to talk a little bit about the differences between the right and left heart and what determines RV function and causes RV dysfunction. Talk a little bit about evaluating the RV, but that's definitely beyond the scope of 15 minutes. And especially spend more time trying to talk about how to treat RV failure and a little bit about its prognosis that's associated. So a few references that I used for this review. In terms of differentiating the right and left, well, I mean, short of both ventricles being in the same heart and sharing an interventricular septum, they're very different, both in size, in shape. So we all know the LV is more of a bullet, sort of elliptoid shape, whereas the RV is a bit more triangular, crescentic, and wraps around the left ventricle. Also worth keeping in mind that it is thinner, it is more trabeculated, which makes it technically more challenging to image, especially by echo. It is bigger, so it has more volumes in both systole and diastole. So by default, its normal or accepted normal RVEF is a little bit less than the left ventricle. And it is, of course, associated and attached to pulmonary vasculature, which is a low pressure system, low resistance system, which makes the RVs work a lot easier than the left ventricle. So to generate the same amount of volume and power, it only requires about 1/6 of the energy than it does for the left ventricle. And it's better adaptable, it's more resilient. It can face big challenges and come back from it sometimes a little bit easier than the left. So worth getting to know the right ventricle. In terms of myofibers, just a brief note that, the LV is a contortionist, right? It can move in so many different ways. So it's got torsion, it's got thickening, it's got a translation motion, but the RV is a lot more simple, and that's because it really has only 2 sets of myofibers. So it has superficial circumferential myofibers that wrap around and are in continuum with the left ventricle, so play a big role in what we're going to talk about after the ventricular interdependence. But mainly the function and the strength of the right ventricles comes from its inner longitudinal fibers, which are worth noting because on imaging, when you're looking at RV function, you're going to look more at the sort of longitudinal movement of it and contraction that go from taking the tricuspid annular and contracting it towards the apex. So a little different in that way as well. Determinants of RV function. So we'll dive right into it. So ventricular interdependence is probably one of the key factors that affect RV function and worth really understanding. So what it refers to in simplistic way would be the fact that the size, the shape, the compliance, and even the sort of pressure volume relationships of one ventricle directly affects that of the other because of their direct mechanical interactions. So there's 2 kinds of interdependence. There's a systolic one and there's a diastolic one. Systolic wise, that's mostly mediated by the interventricular septum, where left ventricle contraction assumes about 20 to 40% of RV systolic pressure, which means that, and we've demonstrated that in certain studies, that as long as the RV is not totally dilated, if it's not working and dysfunctional, it will still, the left ventricle contraction will assume circulation hemodynamic stability, although the RV is not contracting. So we know that in sort of our single ventricle morphologies. And then diastolic interdependence is a little bit more interesting, and the fact that when the right ventricle gets dilated, or if it's faced with really high pressure loads, volume loads, it causes the interventricular septum, to flatten. And when it does, because of the constraints of the pericardium, it shifts it towards the left, and it causes the size, literally, of the left ventricle in diastole to be a little bit less. So it minimizes or decreases the ability for the LV to fill, and in a way, increases LV and diastolic pressure. So that in itself leads to lower LV preload and therefore lower systemic cardiac output. In addition to that, when the right ventricle gets real dilated, again, because of the constraints of the pericardium, you get this pericardial sort of circumferential pressure that also decreases the ability for the LV to fill, and again perpetuates low cardiac output. So it makes the traditional, this concept in itself makes the traditional teaching of acute RV failure with hypotension being a preload problem, and that it requires sort of a blanket statement of IV fluid resuscitation. This whole concept makes it a little bit more simplistic. And so when you overfill the RV, when it's already dilated, because of, in a way, this concept and other things that we'll talk about, it leads to this cascade of RV failure, which we're familiar with. We've seen this before, where the RV dilates, it causes TR, it further dilates, it causes wall tension, it activates a slew of different cascade mechanisms, including decreased RV, coronary perfusion, further ischemia, myocardial demand, decreased contractility, it further dilates, there's more TR, there's more reduced output, the whole aspect of interdependence comes into play here, and then reduced coronary perfusion, and then you get in this vicious spiral that's really bad. So there we are. Other determinants of RV function, afterload and preload. So we know that compared to the left ventricle, the right ventricle does not tolerate abrupt increases in pulmonary artery pressure or pulmonary vascular resistance. We think that, roughly speaking, a normal right ventricle that has never really seen, bad things happen, is usually incapable of generating systolic pressures that are sustainable for a very long time if it's abruptly faced with pulmonary artery pressures, mean PAPs of greater than 40. And so, for the same amount of pulmonary vascular resistance, the stroke volume in the right ventricle is going to decrease very quickly when it's faced to high pressures. Similarly, in terms of preload, the Frank-Starling mechanism applies to the RV as well as the left ventricle. So within physiological limits, if you give the right ventricle a little bit more preload, right, it will still improve its contractility and stroke volume, but perhaps at a narrower range than the left ventricle. So again, beyond that physiological range, excessive RV volume will eventually impair the cardiac output through concepts of this ventricular interdependence, and also because of myocardial ischemia. So this leads us to another determinant of RV function, which is perfusion. So beyond an acute RVMI, where you have abrupt issues with coronary blood flow due to coronary obstruction, you also have to think about the fact that blood flow in the right ventricle is also determined by the difference between wall tension and coronary artery pressure, meaning that really high excess of volume or pressure overload will increase wall tension, reduce the coronary artery perfusion, and increase O2 demands. Similarly, when your right atrial pressures increase, so do your coronary venous congestion pressures, and that also decrease coronary artery perfusion and blood flow. The other cool thing about the RV is that it receives circulation through both systole and diastole. So in conditions that have sustained systemic hypotension, you have to think about the fact that, beyond just monitoring a map, if your systolic arterial pressure is low, then you also will decrease your systolic perfusion to the right ventricle. And this image here just kind of highlights how we have to think about the RV in the same sort of segmental way as we do the left ventricle. And we have to look at it in different views, especially on our imaging modality, to really appreciate how it can be affected, not just in the RV free wall, but also if there's only a PDA lesion, it may be affected only in an inferior aspect of it here, or if the LAD is affected, you have an anterior STEMI, you may also find that you have RV dysfunction in your anterior RV views. So worth just keeping that in mind. So this brings us to another concept of RV dysfunction versus RV failure. So RV dysfunction is simply abnormalities, mostly on imaging of RV structure and or function. And that's caused by all of these determinants that we've kind of touched on already. RV failure, otherwise, is a clinical syndrome that's the manifestation of RV dysfunction. And there are sort of three cardinal features of RV failure. So there's the obvious fluid retention, congestive symptoms that we've all sort of come to appreciate, but there's also low cardiac output. And that one can sometimes be missed and perceived as being something else. So people with RV failure get fatigue, they get low energy, and they get exercise intolerance, again, due to the low cardiac output that it may cause. In addition to that, RV failure in itself can cause dysrhythmia, so atrial ventricular dysrhythmia, fast and slow, and those can also perpetuate RV dysfunction and symptoms of RV failure. In terms of causes of RV dysfunction, I like to think of them in a pathophysiological approach, only because it helps me then target how to best manage the most likely cause for the dysfunction. There's a lot of nuances and crisscrosses between those, and so this is not a pure approach, but it helps. So pressure overload, we think often of acute PE and pulmonary hypertension. Remember that pulmonary hypertension has 5 WHO classes. So pulmonary WHO class 1 is your typical PAH. Class 2 is all of your left-sided heart disease. Class 3, your pulmonary disease. So important to remember sleep breathing disorders such as OSA and hypopnea, hypoventilation syndromes. They're a completely different way of treating it in itself. And CTEPH class 4 is interesting. So worth noting that only about 5% of patients with acute PE will go on to develop CTEPH, and only about a third of patients who have CTEPH have had a history of PE. So both will require different investigations for diagnoses. And then left-sided heart disease, we often think about mitral stenosis, but also mitral regurgitation. So in about 50% of patients with at least severe MR, you'll find that there is pulmonary hypertension from post-capillary causes, and then eventually can get RV dysfunction and RV failure, which complicates everything. Myocardial dysfunction, so we've talked about acute RVMIs. For non-ischemic cardiomyopathies and heart failure reduced EF, more prevalent to have RV dysfunction in non-ischemic cardiomyopathies in about, I think it's, I forget, just under 50% of patients with heart failure reduced EF will have RV systolic dysfunction or some kind of dilation. So that's worth noting. because it has significant prognostic factors associated with that. And usually the degree of LV dysfunction will mirror the degree of RV dysfunction, so you have to look for it. And then sepsis is an interesting one that I don't think we think of very often. So severe sepsis, septic shock, we all know can cause LV systolic dysfunction in itself, but also the right ventricle. Both conditions tends to improve and normalize in patients who survive their sepsis. Tricuspid regurgitation is a big one for volume overload, and TR could be a talk in itself, really. Traditionally, it's sort of also the forgotten valve. And it's thought that, for the most part, it's physiological or, secondary to something else. And for it is usually, but its implications in prognosis, both mortality and morbidity wise, is very important and probably underappreciated. And we know now that, patients who have chronic, significant, moderate to severe or severe TR for a long time, when the right ventricle dilates and becomes dysfunctional, some of it is permanent and some of it is fibrosed myocardium that is not reversible. So keep in mind, the indications to treat TR, and more we're going to hear about percutaneous opportunities to repair that tricuspid regurgitation. So it's coming. So looking forward to that. Otherwise, so management. So full disclosure, this is an evidence-free zone, really. Most recommendations are based on concepts of pathophysiology that make sense, or retrospective trials and very small randomized studies. But this is sort of how I would think of things. So nutrition-wise, everyone should probably get some sort of sodium restriction. Usually less than 2 grams a day is enough. And if someone is really abiding by that, they probably don't need a fluid restriction in addition to sodium restriction, but in extreme cases, you'll want to limit fluid as well to maybe less than 2 liters a day. Daily weigh-ins are crucial. They're so important, both as an outpatient and an inpatient, to accurately and effectively titrate diuretics. Activity in a chronic patient, if you can promote at least moderate exercise training, it is helpful for their survival and their morbidity. Referrals to cardiac rehab can also be useful. Preventative wise, other general concepts: preach medication compliance, teach patients how to self-titrate their diuretics, it's helpful. Compression stockings and keeling wraps go a long way. I avoid NSAIDs in everyone, avoid non-dihydropyridine calcium channel blockers because of their negative inotropy in everyone. And you have to be careful, especially when they develop AFib, to avoid certain antiarrhythmic drugs, especially class 1. Be careful for the use of beta blockers. Unlike HFrEF, there's no target heart rate for RV failure. So too slow is bad, too fast is bad. So the sweet spot, we don't know, but it's probably around 80, 90 beats per minute. And of course, avoid alcohol. If you find a cause for the RV failure, treat it. Worth noting that BiB failure here is really the only indication for the traditional guideline-directed medical therapies, such as ACE inhibitors, ARBs, ARNIs, MRAs, beta blockers, SGLT2 inhibitors. Everything else, there's either no evidence or it can be harmful, especially in PAH. And some of these conditions here can become really complicated, and there are treatment availables for them. And so those patients should probably get referred to their respective specialists for advanced management. Otherwise, in terms of looking at it from sort of, again, a pathophysiological approach, so preload is going to be the mainstay of RV failure management, and assessing it is challenging. So if the patient is in full-on edema, it's useful. If they're in anasarca, if you can tell that there's biomarkers of hepatic congestion, it's helpful. But the JVP can be misleading, right? So we can have tall A waves due to poor RV compliance, not necessarily because of overload fluid-wise. Tall V waves and TR. Your point of care ultrasound will help you, but certainly in acute care, in inpatient, A central venous catheter will go a long way. Even continuously monitoring your CVP will be helpful to kind of guide your filling pressure targets. And a PA catheter, also very helpful. So especially when you're kind of teetering between, you know, should I give fluid? Should I take fluid away? What do we need to do with this person? Even just a diagnostic right heart cath to guide you to know where you're at will be very helpful. Fluid challenges, you can try it. Go small and go slow. So 500 cc bolus challenge will be useful. And if you have no improvement in your blood pressure and indices of cardiac output with that, you should reevaluate and not give a whole lot more, because you'll get into that vicious circle of cascade that we've already talked about. Most patients will require some kind of reduction in preload, so mostly with diuretics, mostly with IV diuretics. So remember that with venous congestion comes gut edema, so your intestinal tract does not absorb nutrients nor medications very well. So these patients often need IV diuretics, often need high doses of IV diuretics, and it wouldn't be uncommon to give high doses bolus or even a continuous infusion of Lasix, or even both. And you may need to add thiazide diuretics such as milrinone, and you may also be considering MRAs for potassium balance, and sometimes even thinking of things like acetazolamide or Diamox when you get into the hypochloremic metabolic alkalosis. But sometimes you'll just have someone who's hypotensive and in an AKI, and you'll just need help and advice, and you know, feel free to think, you know, beyond just diuretics. You may also need to just increase contractile support. You may need to consider ultrafiltration. The important thing to do is just not withhold the diuretics. Even if there's an AKI, even if there's the patient's hypotensive, they need it to restore cardiac output. And you may just need to sort of go over that proverbial hump to get there. And in my sort of approach of sometimes screw the kidneys, save the heart can be applied here, knowing that, you know, it'll get better. Afterload, tough, probably just as tricky as preload in terms of assessment, because oftentimes the conditions that cause afterload increase are chronic and non-reversible, they're not curative, but you can at least try and look to remove factors that contribute to increased pulmonary vascular tone. So if you find hypoxemia, hypercapnia, acidosis, treat it. If the patient is mechanically ventilated, look for lung protective strategies. If they're not, look for potential auto-peeping, especially in COPD patients. A word on pulmonary vasodilators. So inhaled nitric oxide is mainly used in ICU, and that's where some of the data comes from. It can be useful to improve pulmonary hemodynamics in RV failure, especially if there's evidence of elevated PVR. It has a rapid onset, rapid offset. It's inhaled, so there's not a whole lot of systemic hypotension. It also minimizes VQ mismatch exacerbations. There's some evidence to use it in acute RVMI and cardiogenic shock to reduce afterload. Certainly in ARDS, acute PE, used it definitely post LVAD insert and post cardiac transplant. So there's indications for it. It just needs to find the right patient for it. Similarly, for phosphodiesterase inhibitors like sildenafil, very little evidence, but think of it as a vasodilator that will improve your PVR in certain patients, but be careful because it's also a systemic vasodilator, so it needs to be considered with a bit more caution than the inhaled nitric oxide, especially if the patient's acutely ill or unstable. Contraindicated if they're using nitrates, and frowned upon, might be harmful in patients with heart failure, reduced EF, or any sort of left-sided heart disease, especially if there's elevation in the LVEDP, and that's where you have to be careful. If the LVEDP is okay and normal or low, then you're probably fine, but it can precipitate acute pulmonary edema. Contractile support. So there's no such thing as an ideal agent. And for the most part, you'll need a bit of this and a bit of that to make, the outcome that you want. So ideally, you'd be able to increase your systemic arterial pressure and cardiac output while improving RV inotropy, and at least, maybe hopefully decreasing your PVR or keeping PVR neutral. So be careful in thinking of norepi as a blanket agent. It is a vasopressor foremost. It has very little beta-1 stimulating properties. It increases SVR, so it works to improve preload, but it also increases pulmonary vascular resistance, which is bad in RV failure. Vasopressin is maybe underthought of and underutilized. It's very interesting to use because it will increase your SVR. It will give you that oomph if you need it. But it's at least PVR neutral, and in lower doses will reduce your pulmonary vascular resistance. So it's kind of a neat agent to use in RV failure that you need vasotropic agent. And because it's not a catecholamine agent, it won't, or at least it will limit the arrhythmic events that could be associated with other agents. But consider the fact that if you're in RV failure, it's a pump problem, that you probably need more inotropy, and which agent you use depends on the situation. There's a little bit more data and a little bit more knowledge to use dobutamine or milrinone. Both have their pros and cons. We can talk about that, I guess, in a discussion period afterwards, but I'll just kind of keep moving on. Mechanical support is also beyond the scopes of this talk, but worth keeping in mind for the right patient, because the RV, again, is resilient. And it probably just needs a bit more time to get back to where it can function when it's failed. And that can sometimes take weeks. And so weeks on inotropes and vasopressors is not super ideal. But if you can prevent end organ function and give enough time for that RV to recuperate, most of these are temporary and can be removed successfully. And if not, then the appropriate patient should be thought of for potential heart transplant. Other management tips, can't emphasize enough to maintain sinus rhythm. So you'll want to think of rhythm control strategies for AFib, flutter, and other kinds of SVT. Heart rate control, we kind of touched about. There's no point in trying to slam the right ventricle with beta blockers to achieve a heart rate of 50 to 60. It's probably not going to work, and it's not going to help you very much. It needs a little bit of heart rate, but not too much. And look for patients who are paced and maybe VVI pacing, because sometimes restoring AV synchrony can be very helpful. And of course, if they need pacing, to consider dual chamber pacing. There's some kind of evidence coming out for bi-V synchrony and CRT devices, especially if someone has a right bundle branch block that's really, really wide, but the evidence is a bit inconclusive at this point. Systemic blood pressure. So again, because of the concept, few things. So because of the concept of systolic coronary blood flow, you want to keep your systolic arterial pressures high. But also when you get into a situation where the pulmonary artery pressures are becoming systemic and greater than the systolic pressure, then you'll get into some troubles there. So you have to maintain that. Prevention ICD, no real evidence except for tetralogy of Fallot, ARVC, and of course your HFrEF. Atrial septostomy can be thought of as a palliative procedure, and of course transplant when we need it. More hormonal agents we kind of talked about. Evaluating the RV, no time to talk about that, but that may be a talk in itself some other time. With echo, lots of opportunities to look for cool things. Hemodynamics, also very important. We can talk about that another time. So I'll just kind of go to the prognosis implications of RV failure. There's a myriad of conditions for which the RV determines prognosis and management. So that adds importance to know more about this ventricle that is often forgotten. And sure enough, it will always have a place in my right ventricle. So I'm kind of gonna leave it at that for now and see if maybe, I mean, you guys probably have to head off. It's already 8:30, but I have a bit more time if anybody wants to stay along to ask any questions or to kind of talk about cases that have been interesting or challenging.
Thank you, Aimee. This is, very, very good and overview and some interesting tidbits, which I found fascinating. It reminds me of a patient I saw on the weekend that really illustrates the RV, not dysfunction, the RV failure. This was likely obesity, obstructive sleep apnea related. And the patient, by the time we saw them, was an acute renal failure, dialysis dependent, high dose of inotropes, still hypotensive, low cardiac output, as you stated, in pretty terrible shape. And these are the ones that are really challenging in terms of, how, every little small things that we did. And I never in my mind could imagine a reversible cause here other than, so that was my challenge, other than trying to get through this by removing enough fluid over times to get his RV to shrink a little bit and his tricuspid to eventually work and hopefully improve his perfusion. You can imagine his CVP was nearly 30, and it was not good. So just your tidbit when you see a patient like that, when you struggle with not identifying a reversible cause or truly big picture reversible cause, how challenging that is.
It is challenging. I think again, like it's trying to find the right balance between your preload, your afterload, and your contractility. And when you get into, to the point where you're in dialysis, you've got TR, you're hypotensive. I don't even know. I mean, God forbid that person also had AFib to add to that.
Yes.
Then sometimes a right heart cath can just be helpful to either confirm that you're doing everything you can and there's nothing more to optimize, or then you might be like, well, you know what, that PVR is actually really high. Your wedge maybe is okay. What about trying something like inhaled nitric oxide, right?
Yeah.
Maybe it might help, but you're right. Sometimes you just can't, and it is what it is. So if
So
they're young enough, if they're okay, and if you think that the renal dysfunction is acute and a direct sort of consequence of the RV failure, then maybe you can try thinking of listing that person for heart transplant, and then mechanically supporting them while you get there. If you can get there, it's tough.
Yeah, absolutely. I think you're right in terms of if you think they can get better, then aggressive sort of monitoring to help you make the right choice and right call is definitely helpful. So with that, I'm going to close the round. So Aimee is reachable by email. Hopefully you won't flutter with emails with questions. And I really think we should do another session at some point on RV assessment, because I think that's a huge area from a it is hard, and I use a lot of Gestalt when I see patients, look at echo, look at a whole bunch of different things. And it is one of those feared things in my world from a cardiac surgery point of view with RV dysfunction prior to intervention, because I know I make it worse many of the times. And I need that RV to survive certainly the acute period of surgery. And I know my colleagues feel the same way, I'm sure. And then sometimes it's a little bit overlooked as a way to assess patients. Anyways, Aimee, thank you very much for rounds. Thank you, everybody. Back to work. Thank you. Bye-bye.